The meniscal role knee function, that is sharing absorption and the cartilage. The preservation of meniscus is long-term, which is why we thoughtless. And I might add, the first published harm Fairbanks. I worked in Cambridge and Fairbanks and told me in Cambridge in 7 that when he published his after meniscectomy, the bone joints would not publish. It's done by hundreds of us every day and they could cause arthritis. An article titled Active Checkmate, and that's what the power. For the meniscus associated with hip stress and thereby articular cartilage, second of the knee on the medial joint root cartilage and proprioception. If you take meniscus, you contact the area frequently over articular cartilage. So removing a third of the meniscus would reduce contact by 10%, but stress will increase by 65%. If you do a full meniscectomy, cartilage contributes by 65%, which is increased by 130%. And the work of Walker and others published in 1985 shows that lateral meniscus is responsible for 70% of the lower compartment, the medial 50%. And that was correlated with clinically that meniscectomy is a much more malignant operation than medial meniscus. There are several papers that Edison's referred to talking about the consequences of meniscectomy, and these first three late 80s, early 1990s. Jorgen reported on a total of 147 patients a total of meniscectomy. 4% had osteoarthritis in 5 years, and 9% at 14 years. And arthritis is more common in the lower compartment, lateral meniscectomy than medially. Greater proportion of those in athletes. Hoshikawa reported subtotal open meniscus in 60 patients at a 5-year follow-up, and he put patients into international athlete versus competitive recreational weekend, and there were much results in the international athlete group and much worse in volume. Roos reported in 1984 286 football players who had an open total meniscectomy, and he looked at the incidence of osteoarthritis. In the control group, there was 1.6% of osteoarthritis, 4.2% in the non-elite players, and 15.5% in professional players. So meniscectomy is a bad thing to do, certainly total meniscectomy, and it seems to be worse in athletes in terms of the amount of arthritis that's produced and the speed with which it occurs. If you look at the consequences of partial meniscectomy, Porno reported 177 patients up to 8 years follow-up, and 53% had degenerative changes. So even taking out part of the meniscus is a bad thing to do to the knee in terms of arthritis. Ranger, 284 patients, 4-year follow-up, a little worse, surprisingly, in the medial compartment. Gucci, 82 patients, he followed 80% of them up to 12 years, and 34% had more degeneration in the operated knee. Those are similar results, 37 patients at 10 years and 97% had degenerative changes. So even a partial meniscectomy is not a good idea. And if we look at the changes in partial meniscectomy in athletes, Bono reported 31 patients with a follow-up of 8 years, good and excellent results, but the Tegner scores went down from 7.2 to 5.7 and 92.7% had degenerative changes. Mariana, similar, he presented just 5 football players with varus knees. These are soccer players with varus knees who ought to have more load on the medial side. They had lateral meniscectomy, and the vast majority of them had lateral pain, and this was a small group of patients with chondrolysis. So lateral meniscectomy is a particularly bad thing to do to a football player, soccer player, even when they're in varus. So it's worth trying to preserve the meniscus if you can, and certainly from that data, I think Edison's shown us that meniscectomy produces bad results in the longer term. Enendar was the first person to describe a meniscal repair in 1885 in the British Medical Journal, and we've continued to try and attempt to repair the meniscus despite the fact that it doesn't always work. There are a number of factors to consider in whether we'll repair a meniscus, including the age of the patient, the type of tear and its location, orientation, whether the joint is stable, how long the meniscus has been torn, and what the articular cartilage is like. But our objectives when we attempt to repair a meniscus is obviously to allow that meniscus to function, to take load, and to maintain the integrity of the articular cartilage. So let's go over the factors to consider. Firstly, the location of the tear. It can be anterior or posterior, medial or lateral, but the most important factor in the location is the vascularity, and that of course means its closeness to the periphery of the meniscus. Somewhere between 10 and 30% of the meniscus has a blood flow, as you can see from these in ink stains, and they have the capacity to repair. The type of tear is a factor to consider in whether to repair. Big tears are less likely to heal. Essentially, if the tear has innate stability, it's more likely to heal. The plane of the tear is very important, and in particular radial tears have a very low likelihood of healing, and of course simple versus complex tears. So here you have a bucket handle tear which is big above and a small bucket handle tear. Those longitudinal tears, good chance of healing, but the horizontal tear bottom right and the radial tears, less likely to heal. And of course add to that the age of the patient, the demands and the level of meniscal degeneration. Age is not necessarily an absolute factor in determining whether a patient is a candidate for meniscal repair, but with advancing ages, the nature of the meniscus is predominantly degenerate, and so they are predominantly irreparable. Looking at tear types, there's a lack of tissue viability and a tendency to do meniscal resections in patients that have multiple plain tears, and radial and horizontal tears do not, as a rule, heal well. So in general, in short term, if an athlete has a meniscal tear and we do a meniscectomy, there's less recovery time and they're a happier patient. However, in the longer term, meniscal repair, whilst it might be associated with a short-term disadvantage, has a more favourable prognosis in terms of arthritis. So let's look at the technical issues. Essentially it comes down to, in a decision that a surgeon has to make as to whether he repairs the meniscus, is whether or not he's able to reduce the meniscus and whether he can hold it there. And they're the two most important factors the surgeon has to consider. I think the surgeon also has to consider that there are some surgeons that will not repair any meniscus, and there are some that will over-repair menisci. And they have to accept, or we have to accept when we repair menisci, that we will have colleagues that will argue with us and will say that the meniscal repair, irrespective of whether it's done or not, doesn't function. So let's go through the techniques. We can have an inside-out technique, an outside-in technique, or an all-inside technique. We can vary our fixation type, we can vary the extent of repair, and of course, if the knee is unstable, it's important to add an anterior cruciate reconstruction, or PCL, depending on the instability. The gold standard of meniscal repair is a suture inside out. It's important when you're doing that suturing that you don't damage the articular cartilage, and you can use various techniques, foot rests and so on, to do that. Surgeons need to have more than one method of fixation available. They also need to attempt to maximise healing. Trephining the meniscus will help cause injury to nearby tissue with blood flow, and that will help allow cells to come in and improve repair. It's really important to get an anatomical repair. It's a bit like an orthopaedic surgeon stabilising a fracture. We like to have the fracture reduced anatomically and then compressed, and the same with the meniscus. If you can get it reduced anatomically and compressed with sutures, it's much more likely to heal, particularly if you leave a stable fixation. There's also no doubt that we have a much greater success in repairing lateral menisci, and that's no surprise when you look at a sagittal view of the lateral side of the knee. All the forces are to push the meniscus back into position with the bucket handle tear. So we do much better on the lateral side than on the medial side. If we look at the results of meniscal suture, Chang in 2005 looked at biomechanical evaluation of slip and point of failure, and he concluded that a vertical suture inside out with as much of the meniscal tissue as you could grab was the strongest form of fixation. Kalasmarkas performed a randomised study looking at a comparison of implants, and he had an 86 to 92% incidence of healing without any particular difference within the two devices that he used, which was a suture and a meniscal arrow. Briggs and Barber and Cohen have all demonstrated quite good success with meniscal repairs, and the gold standard remains a vertical mattress suture. If you look at these tables here, the ones up the top here, the staples and Mytech repair systems and screws and arrows, they all have a very, very low pull-out strength. And if you look down the bottom in the red, you can see the double vertical mattress is the strongest suture with a pull-out strength of 113 newtons, and that remains the gold standard. So if you've repaired a meniscus, what do you do with the patient afterwards? Well, we know that the ultimate strength to failure is about 50% of the normal meniscus at 3 to 4 weeks, 80% at 8 to 12 weeks, and 100% at 14 to 18 weeks. So you can take that into account in your healing, but you can also do other things to help that meniscus heal. There's no question that ACL reconstruction is a good thing to do in association with a meniscal tear, and presumably the blood that's in the knee from the drilling of the tunnels does improve the healing process, but you can also have some synovial response by trephining near the tear, and hopefully that gives some vascular enhancement. So what do we do with the patients after they've had a meniscal repair? Well, the important thing is to protect that repair by restricting their knee flexion to less than 90 degrees, and typically that's done for between 4 and 6 weeks. And that, of course, helps protect the repair and the articular cartilage. So in summary, meniscectomy results in osteoarthritis, and there are numerous studies to show that. And that osteoarthritis is more common in the athlete than in the non-athlete. So it's reasonable to repair a meniscus, but we have to accept that not all tears are repairable, but we should repair a meniscus if it's feasible and if it's going to work. And we should also accept that we're going to have some failures. If you repair menisci and you never have a failure, that means that there are some menisci you take out that might well have healed. So in fact it's imperative to have some failures in meniscal tears that you attempt to repair, otherwise you're doing too many meniscectomies. That's more likely to heal the meniscus if it's well reduced and if it's held with vertical natural sutures, and we should protect that repair for somewhere between 12 and 18 weeks. Thanks.